Comprehensive home treatments for nail fungus, non-prescription strategies for success. Nail fungus, onychomycosis, is a common, persistent condition that can mimic or coexist with non-fungal disorders like psoriasis, trauma, or lichen planus. Diagnostic testing is often necessary before starting treatment. While oral antifungals are effective, they carry risks like liver toxicity and drug interactions. As a result, some turn to home-based alternatives. This article explores scientifically supported home remedies, their mechanisms, risks, and safe combination with prescription topicals when needed. Caution is advised when combining remedies with topicals, as interactions may enhance absorption and side effects. Due to allergen risks, a patch test and monitoring for reactions, e.g., redness, itching, swelling, are recommended before applying remedies. Understanding nail fungus. Nail fungus occurs when fungi infect the nail bed, causing discoloration, thickening, and brittleness. The condition is challenging due to nail as a barrier. The thick nail plate impedes topical treatment penetration. Fungal biofilms, protective layers fungi form that resist treatment. These increase resistance to topicals and antiseptics, contributing to treatment failure. Slow nail growth. Toenails grow slowly, 1 to 1.5 mm/month, compared to fingernails, 3 to 4 mm/month, requiring 6 to 12 months for improvement. High recurrence rate. Fungal spores persist in shoes, socks, and skin, increasing reinfection risk. Healthcare providers often focus on management rather than cure when oral medications are avoided. Home remedies are most effective for mild cases or as adjuncts to professional treatments. Ineffective prescribed topical antifungals, e.g., clotrimazole, cyclopirox, may result from biofilms, poor penetration, fungal resistance, or insufficient nail preparation. Thorough debridement, removal of thickened nail, is critical to enhance topical efficacy, especially given biofilm resistance. Home-based management strategies. Thorough debridement, removal of thickened nail, either through careful home filing or professional care, is the single most important step to thin nails and allow topical treatments, prescription or home remedies, to penetrate the nail bed. The remedies below have varying evidence levels, strong, moderate, weak, based on clinical or in vitro studies. Some, like sea salt and baking soda, are traditionally used but lack robust human trials. A patch test, apply a small amount to the inner forearm and monitor for redness, swelling, or itching over 24 hours, discontinue if irritation occurs, and monitoring for allergic reactions are advised for vinegar, tea tree oil, or hand sanitizer. Avoid layering multiple home remedies simultaneously, e.g., vinegar, tea tree oil, hand sanitizer, as this may increase irritation or unintended absorption of prescription topicals. Table 1. Summary of home remedies for nail fungus management. Remedy. Mechanism of action. Evidence strength. Frequency. Precautions. Nail care. Improves penetration, hygiene. Strong. Daily trimming/filing. Avoid aggressive scraping. Sterilize tools to prevent spread. White vinegar. Acidic environment inhibits/kills fungi. Moderate. Soak, 15 to 20 minute daily. Spot, 1-2x/day. Patch test, dilute if irritated. Avoid wounds, dry thoroughly. Baking soda. Raises pH, absorbs moisture. Weak. Soak, 2-3x/week. Sprinkle, daily. Limited evidence. Avoid overuse to prevent dryness. Sea salt. Osmotic effect inhibits growth. Weak. Soak, 2-3x/week. Limited evidence. Dry thoroughly to avoid moisture retention. Hand sanitizer. Surface disinfection, alcohol-based. Weak. 1 to 2 drops daily, post-bath/bedtime. Patch test, limit to 1x/day. Avoid wounds, not primary treatment. Tea tree oil. Disrupts fungal membranes, terpenin, 4-OL. Moderate. Diluted, 1x/day. Undiluted, 2x/day. Patch test, high irritation risk if undiluted, discontinue if irritated. Nail care and preparation, evidence, strong, clinical consensus, proper nail maintenance enhances treatment effectiveness and reduces fungal spread. Trim nails short and straight across using clean clippers, then file thickened areas gently to thin the nail. Use a disposable emery board or sterilize metal files with rubbing alcohol or hand sanitizer, 60 to 70% ethanol/isopropyl alcohol, after use to prevent cross-contamination. Clean gently under nails with a soft brush and mild soap. Avoid aggressive scraping to prevent micro-tears that worsen infection. Keep nails dry, as moisture promotes fungal growth. After bathing or soaking, dry feet thoroughly, especially between toes, using a clean towel or hairdryer on a cool setting. Optimization tip: soften nails by soaking in warm water for 10 minutes before filing or applying treatments to reduce brittleness. This is critical when topical creams are ineffective, as thickened nails act as an impermeable barrier. Gupta and Simpson, 2013. Vinegar treatment, evidence, moderate. In vivo studies, vinegar, acetic acid, inhibits or kills surface fungi by creating an acidic environment, fungistatic, slows fungal growth, or fungicidal. White vinegar is recommended for its consistent 5% acetic acid content, ensuring predictable pH alteration, though apple cider vinegar, ACV, for 5% acetic acid, has shown efficacy. Weichel et al., 2021. Soak, mix 1 part white vinegar with 2 to 3 parts warm water, not hot, to avoid irritation, and soak affected nails for 15 to 20 minutes daily. Start with once daily and increase to twice if tolerated. ACV may be used if white vinegar is unavailable, but its concentration may vary slightly. Soaks increase moisture exposure, so dry nails and surrounding skin thoroughly afterward to avoid promoting fungal growth. Spot application: mix 1:1 white vinegar and water, apply with a cotton swab to the nail, and optionally wrap lightly with a bandage for 30 to 60 minutes. Repeat 1 to 2 times daily. Precautions: irritation, redness, stinging, may occur, especially on cracked skin. Dilute further, 1 to 3 ratio, or discontinue if persistent. Avoid open wounds. Perform a patch test, apply a small amount to the inner forearm and monitor for redness, swelling, or itching over 24 hours, discontinue if irritation occurs. Apply a gentle moisturizer, e.g., petroleum jelly, if skin becomes dry. Consult a healthcare provider before combining with prescription topicals, as vinegar may enhance drug absorption and increase side effects. Weichel et al., 2021. Baking soda, evidence, weak. In vitro studies, baking soda, sodium bicarbonate, is fungistatic, primarily by increasing pH, alkaline environment, to inhibit fungi, and secondarily by absorbing moisture. Sprinkle 1 to 2 teaspoons in shoes or socks daily to maintain a dry, alkaline environment, or use in foot soaks, a quarter cup in warm water, 10 to 15 minutes, 2 to 3 times weekly. Best used alongside other treatments. Human clinical studies are limited. Magliano et al., 2012. Sea salt soaks, evidence, weak. In vitro studies, sea salt inhibits fungal growth and reduces inflammation, likely via osmotic effects. Dissolve 1 to 2 tablespoons in warm water and soak feet for 10 to 15 minutes, 2 to 3 times weekly. Soaks increase moisture exposure, so dry nails and surrounding skin thoroughly afterward to avoid promoting fungal growth. Works best in combination with other treatments. Human clinical studies are limited, Ali et al., 2020. Hand sanitizer, alcohol-based, evidence, weak, in vitro antiseptic studies, alcohol-based hand sanitizers, 60 to 70% ethanol or isopropyl alcohol, reduce fungal load on the nail surface and surrounding skin, particularly when applied to clean, dry nails after bathing or at bedtime. Alcohol's volatility limits its contact time, making it a hygiene and support tool for surface disinfection or tool sterilization, not a treatment for subungual infections. Application: apply 1 to 2 drops of hand sanitizer, gel or liquid, greater than or equal to 60% alcohol, to the affected nail and surrounding skin using a clean cotton swab or fingertip. Allow to air dry for 1 to 2 minutes. Use once daily, ideally after bathing or at bedtime. Precautions: limit to once daily to avoid dryness or cracking. Follow with a moisturizer, e.g., petroleum jelly, if dryness occurs. Do not apply to open wounds or severely irritated skin. Perform a patch test, apply a small amount to the inner forearm and monitor for redness, swelling, or itching over 24 hours, discontinue if irritation occurs. Consult a healthcare provider before combining with prescription topicals, as alcohol may enhance drug absorption. McDonnell and Russell, 1999. Tool disinfection: wipe nail tools with hand sanitizer after use to eliminate fungal spores. Supportive measures. Tea tree oil, evidence, moderate, small clinical studies contains terpenin, 4-OL, an antifungal agent. Research supports undiluted, 100%, tea tree oil applied twice daily for 6 months for mild cases, but due to high risk of allergic contact dermatitis, dilution is advised for home use. Dilute 1 to 2 drops of 100% tea tree oil with a carrier oil, e.g., coconut oil, and apply to the nail once daily after bathing or hand sanitizer use. Allergic reactions, rash, itching, swelling, are possible. Perform a patch test, apply a small amount of diluted oil to the inner forearm and monitor for redness, swelling, or itching over 24 hours, discontinue if irritation occurs. Buck et al., 1994. Maintain foot hygiene, change socks daily, moisture-wicking materials like cotton or bamboo, wear breathable shoes, leather or mesh, and avoid walking barefoot in communal areas, e.g., pools, gyms. Disinfect shoes weekly with antifungal sprays, e.g., tolnaftate-based, hand sanitizer, applied to insoles and dried, UV shoe sanitizers, or antifungal laundry detergents, e.g., Defense soap, Hex Performance, for socks and insoles. Rotate shoes daily to allow drying. Avoid occlusive products like nail polish during treatment, unless antifungal formulated, as they trap moisture and worsen infection. Combination therapies. Combining remedies targets fungi through multiple mechanisms, e.g., pH alteration, moisture control, antifungal action, though biofilms may limit efficacy. Avoid layering multiple home remedies simultaneously, e.g., vinegar, tea tree oil, hand sanitizer, as this may increase irritation or unintended absorption of prescription topicals. Below are protocols integrating prescribed topical creams and hand sanitizer, with caution for interactions. Basic combo: after bathing, apply hand sanitizer to nails and skin for surface disinfection, let dry, then apply prescribed topical cream. Sprinkle baking soda in shoes daily to maintain an alkaline, dry environment. Enhanced combo for ineffective topicals: soak in diluted white vinegar, 15 minutes daily, dry thoroughly, apply hand sanitizer, 1 to 2 drops, once daily after bathing or at bedtime, for surface hygiene, then apply prescribed topical cream, followed by diluted tea tree oil, alternate days with hand sanitizer to avoid dryness. Use sea salt or baking soda soaks 2 to 3 times weekly. Pair with over-the-counter clotrimazole cream if approved by a healthcare provider. Apply prescription cream first, then home remedies. Consult a healthcare provider to assess risks of enhanced drug absorption from combining remedies. Monitoring: take photos every 2 to 4 weeks to track progress. If no improvement after 3 months, adjust combinations or consult a professional, as biofilms or misdiagnosis may be factors. Hand sanitizer is a hygiene tool and should not be relied upon as a primary treatment. Additional strategies when topicals are ineffective. If prescribed topical antifungals are ineffective, likely due to biofilms, nail thickness, or misdiagnosis, consider discussing these with a healthcare provider. Urea-based creams, over-the-counter or prescription urea, 40%, creams soften and thicken nails, improving antifungal penetration. Apply nightly to the nail only, under occlusion, covering the nail to enhance absorption, e.g., with plastic wrap, for 1 to 2 weeks for non-invasive debridement. Protect surrounding skin with a barrier, e.g., petroleum jelly, to prevent irritation, maceration, or chemical burns. Mechanical debridement: a podiatrist or dermatologist can remove infected nail portions, reducing fungal load and biofilms. Repeat every 6 to 8 weeks. Home filing can complement professional debridement but requires care to avoid damage. Advanced topicals: switch to better penetrating options like efinaconazole, Jublia, or tavaparole, Keratin, or compounded formulations with antifungals and penetration enhancers, e.g., DMSO. Compounded topicals with DMSO should only be obtained through licensed compounding pharmacies under medical supervision to avoid risks of irritation or systemic side effects. Laser therapy: non-invasive lasers, e.g., ND-YAG, target fungi and disrupt biofilms, showing 60 to 70% improvement in mild to moderate cases after 3 to 4 sessions, Gupta and Simpson, 2013. Diagnostic testing: a nail clipping culture, PCR test, or histopathology can confirm fungal type, as non-fungal conditions, e.g., psoriasis, trauma, lichen planus, melanoma, may mimic symptoms. Managing expectations. Home remedies can suppress fungal growth and improve nail appearance but are unlikely to cure severe or deep infections, particularly due to biofilms and slow nail growth. Consistency over 6 to 12 months is critical, as even successful treatments require time to show results. Below is a timeline comparing nail growth. Nail type. Growth rate. Time to fully replace. Implication. Fingernails: 3 to 4 mm/month. 3 to 6 months. Faster visible improvement. Toenails: 1 to 1.5 mm/month. 6 to 12 months. Requires long-term adherence. These approaches are ideal for mild symptoms but less effective for advanced infections or comorbidities like diabetes. If topicals remain ineffective, professional interventions like laser or debridement are critical. When to seek professional care. If symptoms worsen, e.g., pain, swelling, pus, persist beyond 3 to 6 months, involve multiple nails, or occur with comorbidities, e.g., diabetes, consult a podiatrist or dermatologist. Diagnostic testing, e.g., nail clipping culture, PCR, histopathology, is strongly recommended to confirm fungal infection, as up to 50% of suspected cases may be non-fungal, e.g., psoriasis, trauma, lichen planus, melanoma. Advanced treatments like efinaconazole or laser therapy may be advised. Seek immediate care for compromised immunity or circulation issues. If oral antifungals are avoided due to risks, request alternatives like urea creams, compounded topicals, or laser therapy referrals. A second opinion may be warranted if current treatments remain ineffective. Conclusion. Managing nail fungus without prescription medications involves proper nail care, thorough debridement, topical treatments, preventive measures, and strategic combinations. Home remedies like white vinegar, moderate evidence; baking soda, weak evidence; sea salt, weak evidence; tea tree oil, moderate evidence; and hand sanitizer, weak evidence, hygiene tool, can support management and improve nail health, especially when prescribed topicals fail. Consulting a healthcare professional before starting new treatments or combining with prescription medications is essential to avoid interactions or side effects, particularly with pre-existing conditions. Diagnostic testing is critical to ensure accurate treatment, given the risk of misdiagnosis. References.